Hi, I'm Roger Margolis, Research Director at O'Reilly, and I'm here with John Halamka. And normally I go through all the things that you are, but you have terabytes of things you are, so I thought that we'd start with you explaining all the roles you fill.
Well, happy to be here. And so I'm the Chief Information Officer at Beth Israel Deaconess Medical Center. I'm an emergency physician. As a state, the Commonwealth of Massachusetts does a lot of data sharing, and I am on many of the committees overseeing data sharing. The national role I play is overseeing the Standards Committee, which is helping with meaningful use and ensuring data liquidity for patients, providers, and payers.
What a perfect thing for this conference, data liquidity.
Absolutely.
Something we care a lot about. So you've done a lot of work with health and IT, and you obviously have the health background. Like when did this start? There's this, how far back does it go that you were interested in bringing the two together?
So my life has always been this dual career of medicine and technology. When I was 12 years old, my parents went off to law school. I was a latchkey child in Southern California, and I spent my time in surplus stores picking up used integrated circuits. Taught myself analog and digital logic, then assembly language programming. This was the glory days. 2K of memory. What are you going to do with all that? And so when I became an undergraduate, I started writing software with a real interest in biological sciences and healthcare. And then, of course, medical school and residency was a natural progression. Take that computer science and engineering knowledge, merge it with medicine, and work on healthcare IT.
That's great. I actually think that interdisciplinary is so important. I mean, it's great that people write compilers,
right?
But I think I was going to say quantum leaps, which, just as an aside, a quantum is the smallest movement of energy, and we use quantum leap to mean a big thing. But the big steps happen when you bring two things together. So I think that's great that you happen to luck into having surplus storage with integrated circuits.
Exactly.
Health records, I think most people here at this conference would agree, they're a bit of a mixed bag. They're designed for billing, and we're trying to use them for medical research. Right. Can you give some examples of how you think they can be used for the good? I mean, you're obviously in it a lot, and you're doing these standards. Taking their pedigree, how do we kind of make more use out of them?
Sure. So politics aside, the Affordable Care Act is about reimbursing doctors for quality and outcomes and wellness rather than episodic sickness.
Right.
So you actually can't keep a patient well, keep them in their home, and respect their preferences unless you collect data about them from all kinds of places, whether that's electronic health records, personal health records, telemetry from the home. So what you're seeing is the new reimbursement models are actually driving accountable care organizations to move from a billing-centric fee-for-service world to a data and wisdom-centric and prospective rather than retrospective look at the data. I've spent the last couple of years building all the infrastructure for our accountable care organization. It's one of the very few in America that's actually profitable this year.
That's great. I'm a Kaiser member, and I love Kaiser.
Absolutely.
And I'm almost surprised when I hear about the other ways that traditional healthcare has worked. And I'm actually a big fan of the ACO model, so I think you're definitely spot on with that. The High-Tech Act helped bring EMRs to a lot of places. My wife works at a nonprofit small health provider. They have an EMR because of the High-Tech Act. Is it being accepted? Are doctors into it? I know there's some resistance in some quarters. What do you think?
So I've worked in multiple administrations in Washington, and what you've actually seen in this administration, because of high-tech, is a change in culture. So sure, you could argue that the technology that we're using in healthcare isn't quite the same technology as in the consumer space or, say, retail or financial services. But if you walk into a cafeteria and you start talking about ICD-10, meaningful use, omnibus rule, everyone knows what you're talking about. 5 years ago, they'd say, what? So, in fact, I'm seeing in Boston that unless you're on an electronic health record as a specialist, you won't get referrals. Because there's this expectation that you're going to be interacting with our community in a fully electronic way. So absolutely has changed society.
Yeah, I would totally agree. And just for what it's worth, in fact, I just was published in an industrial relations journal doing a study on whether the High-Tech Act created jobs. And it created a lot of jobs. So it all over the place. And I also saw, I went to Nashville, Tennessee on a trip, met a lot of medical people. This was last year, a sea change in how people are thinking about it. I don't think it's the government. It's like there's an existential crisis we've got to resolve it.
Completely agree. And I have a lot of friends at HCA, and they've moved from what we'd call sort of the mechanics of collecting data for billing to truly clinical outcomes-focused IT. Totally different approach.
Yeah, and it just sounds like it'll be better for everyone involved, which is a segue into, so you've been in this, you're obviously looking out a little bit.
Right.
I'd love to know what you're thinking is going to be happening downstream.
So we're moving beyond the EHR, the PHR, these traditional ways of gathering data, to what I'm calling the care management medical record, where imagine non-physician extenders are looking at all the data from all the various sources and saying, you have diabetes. Well, based on the diabetes protocol, you haven't had a foot exam in 6 months. You haven't had an eye exam. Oh, your hemoglobin A1C is trending a little up. And your glucometer, looks like you're eating donuts for breakfast, lunch, and dinner. So they make interventions by sending home care nurses, preventing you from going to the ED or the hospital because we're keeping you well at home. So we're investing $7 million this year in this effort and have put in not a lot of IT, but most importantly, processes and people to make it happen.
I'm really happy to hear that, as I think that, like I said earlier, that's what helps better outcomes. People have happier lives. I think it just works so well. Well, we really appreciate you coming, and we really appreciate the work you're doing. I think it's really important for moving things in the direction we want.
Well, O'Reilly is a catalyst for change, so happy to be here.
Great. Thanks.